All right, good morning and good afternoon to everyone. Let's go ahead and begin. My name is Greg Schneider and I'm the Chief Marketing Officer at Cadence. And I'd like to start by thanking everyone for attending today's webinar, which is entitled How mHealth Fairview is Using AI and Real-Time Operations to Navigate the Next Normal. Next slide, please. Joining me today as the primary speakers on the webinar will be, first of all, Mudith Garg. Mudith is co-founder and CEO of Cadence. Prior to Cadence, he co-founded multiple technology companies, including Vidopia and Hive. He also spent time in McKinsey & Company's healthcare practice, helping large providers with organizational transformation and performance improvement initiatives. He's been recognized for leadership as one of the Silicon Valley Business Journal's 40 under 40. And secondly, Dr. Karen Baum. Dr. Baum is professor of medicine in the School of Medicine and adjunct professor in the School of Public Health at the University of Minnesota. And she's also vice president, system clinical operations for mHealth Fairview. In her role as VP, she leads system patient access and patient flow across mHealth Fairview, which is the largest health system in Minnesota. In response to COVID, Dr. Baum led the implementation of real-time electronic boards, identifying system resources such as ventilators and ICU beds. She led a predictive model that's used by 8 health systems in the state of Minnesota to coordinate COVID efforts, as well as a surgical planner to safely restart elective procedures while maintaining capacity for COVID patients. As medical lead for their System Operations Center, Dr. Baum was a member of the Incident Command and co-led overall surge planning for the 13 hospital system. And we'll hear much more about all of this later today. So thank you to both very much for joining the webinar. We have a really informative session lined up today. Before we get into that though, I wanted to provide just some brief background on Cadence for those of you who are not familiar with the company. So we are the first patient flow automation solution for healthcare. We take modern innovations in AI and machine learning, in behavioral science, and in operations management, and we apply them to hospital operations. We have a long and proven track record with over 120 successful deployments in the US and Canada in a range of organizations across large health systems, academic medical centers, and community hospitals as well. And we're helping our partners really achieve transformative results, up to 0.8-day reductions in inpatient length of stay, 15% plus reductions in ED length of stay, 23% lower PACU exit delays, and much more. We help enhance the lives of frontline teams, increase the value of your EHR, and improve the quality of care. Next slide, thanks. As I mentioned, we have a really informative session lined up today. Mudith is going to kick things off by reviewing the current environment in terms of challenges and opportunities. He'll then provide some brief context around how you can use AI and real-time technologies to drive operational excellence. And then we'll turn to Dr. Baum and the mHealth Fairview case study, where we'll spend the bulk of the session. And then finally, we'll close with Q&A at the end. A note on Q&A, if you have questions throughout the event, you can enter them into the questions panel that's at the bottom of your screen, and we'll answer them at the end of the session. And then just to preempt everyone's kind of favorite question, which is regarding whether or not the slides will be available. Yes, absolutely, we'll send the slides and a recording of the webinar out to everyone after the event. So with that, it's now my pleasure to introduce Cadence co-founder and CEO, Mudith Garg.
Thank you, Greg, and good morning, everyone. Thank you for joining us today. To start with, I just wanted to start with a little bit of grounding, sort of where we are today, and it's no news to everyone on the call, but the first half of this year has been unparalleled in the history of healthcare and the history of our economy and the history of the country. We know how much of an enormous disruption the pandemic has caused in many, many different areas. It has created an unprecedented financial pressure because of canceled surgeries, the economics of COVID patients, and much more. The AHA estimated about a $200 billion plus loss for America's healthcare systems and hospitals, and that doesn't even include the cost of expanding capacity that we've all had to sustain. We've all seen significant losses of jobs across the economy, but actually paradoxically also in healthcare as well, given those financial pressures. It's affected, of course, the health of our coworkers, of the patients and families and communities across the country. And now, as we look ahead into the second half of the year, while we've seen an ability to flatten the curve, there are a confluence of factors that now present themselves for the second half of the year that have a potential to be a sort of an unfortunate perfect storm for the industry. We are now on the backs of significant lost revenues, a huge backlog of surgeries and patient care that had to be delayed or canceled in the time of the first peak. Our staff, who have just risen above and beyond to take care of these patients and often face pay cuts and furloughs along the way, many of whom are burned out. We have the potential of our seasonal influenza season potentially lining up with resurging COVID in the second half of the year. And whether these headwinds come together as a perfect storm like happened in the 1918 Spanish flu, or they simply contribute to a long unsettled period of troubled weather, is going to be really difficult to manage for months or potentially 12 to 18 months going forward. As we work with our customers across the country, what we have heard is one of the growing realizations in the time of this pandemic has been an acceleration towards Medicare break-even. We've been for a long time in an environment where margins have been shrinking, and now the demographic has been shifting from high-margin commercial payers to lower-margin Medicare businesses. A few years ago, the CBO had estimated that about 40 to 50% of patients of hospitals could have negative margins by 2025. But COVID has created new shocks to this environment. Revenues are down overall. Revenues that have gone away have traditionally been the higher margin parts of the revenue, and that's been replaced by where we have traditionally struggled to keep costs in check, which is the medicine patients and where our margins have been lower often in the government payer patients. And as that sort of goes forward, there's an increasing focus and realization that achieving Medicare break-even as a starting point to achieving the cost efficiencies to serve our population cost effectively is going to be even more critical than ever before right now. But there has been a big silver lining in this pandemic as well. It has been amazing and incredible, and as Dr. Baum's going to be reflecting on her organization's response, to see organizations across the country just move at unbelievable pace to respond to the pandemic. With necessity being the mother of invention, we've seen amazing and impressive actions and inventiveness that partners have stood up new hospitals, new protocols, purchased and implemented new software. Telehealth's the classic poster child example of that, where organizations have compressed their 4 or 5 year roadmaps of adoption into 4 or 5 weeks. These are not just strategies for short-term responses to COVID. We are hearing from a lot of organizations, and as is mentioned in this HBR article by the Geisinger team, that we are now all looking to harness this newfound bias to action for more. We cannot afford to just return to business as usual from a pre-pandemic level, but we need to use this opportunity to really create a new normal and transform healthcare in ways that perhaps were assumed to be unachievable prior to the pandemic. So where are organizations focusing as a result of this? One of the biggest opportunities we are hearing from health systems is the leverage that operational excellence provides in a time of uncertainty like this. If you have the ability to both adapt and then execute with precision, we find that those organizations have higher resilience and are able to go through such pandemics and such shocks to the system much, much better. What more, there are new innovations in AI and behavior science that allow you to do that more effectively now. And we'll highlight 2 specific aspects of that are pretty key. One is how to use that to manage and reduce the length of stay and manage the flow of patients through the hospital, which, as you all know, has been absolutely critical given the focus on hospital capacity in this pandemic. And the second, I think that sort of transcends multiple areas, is how to augment decision-making across the organization. And these both have pretty significant impact Of course, reducing length of stay helps you improve revenues, have greater patients and case volumes be serviced under the same fixed asset base, reduce your cost of serving those patients, and expand effective capacity without requiring additional build or additional staff. But at the same time, this ability to create this seamless decision making between frontlines and systems allows you to reduce frontline burdens, improving execution, and improving patient care as well. So I'll share some examples of how that looks like in practice. First, I think this is an example of how the ability to have much more precise planning actually allows you to make much better use of your resources and unlocks additional revenue. So shown here are two examples of planning and planning models, right? So if you think of the time ahead of us, where there's going to be multiple mini peaks and major peaks of resurgence of COVID, this becomes really critical. The example shown above is an example of an illustrative industry model that we use, where what you see is being off on the prediction of COVID and the buffer that you would require ends up having you to shut down care significantly ahead, versus being much more precise in understanding these little peaks that are going to come and go going forward. You are able to actually service about 20% more of your surgical backlog, which is almost $12.5 million in additional revenue. That not only creates the ability to continue to serve your patients better, but creates the financial wherewithal to be able to weather the multiple peaks of the pandemic that come and go. The other piece that is actually really critical in this operational excellence is what reducing length of stay can mean for your effective capacity. The first go around, we had to create effective capacity, as I said, largely by A, shutting down services, and B, trying to create hallway beds and other ways of increasing capacity where we can. We found pretty quickly that while we can create physical capacity, staffing is often a constraint. So we need to be a lot more intelligent this time around in how we create capacity. And this is an example 300-bed hospital where if you look at the analysis, you can see that a half a day reduction of length of stay can unlock 9,000 patient days in that environment, which is about a $9 million of cost reduction. But more importantly, it creates bed capacity for 16 patient admits, surgeries, both COVID and non-COVID in that time without requiring additional floor staff. And that kind of an ability allows you to weather many more of these, as I said, resurging mini peaks that might come in the future. And that prior example was just for a single hospital. When you look at the financial impact of reducing length of stay like that across the whole system, this example shown here is an example of a 5-facility system where the impact of that is about a $60 million cost reduction that is able to improve sort of your margins as well. As you can see from both these examples, this ability to have this operational excellence can be truly powerful. So now that's amazing. I'm sure the question on your minds is how to leverage AI, how to leverage real-time technology, and how do you actually put all this to practice? You know, our belief, of course, biased a bit, is that we can be a part of that answer. And I'll provide a brief intro to how we do that as we segue into the Fairview case study with Dr. Baum. So first of all, I think this ability to create operational excellence, to create reliability in your operations, it's been a journey for us of thinking about how to create that in organizations. And I think this has been a goal of many organizations for a while. What we found, while data is extremely powerful in driving that, we found that traditional ways of just surfacing reports has been really hard to leverage to actually create lasting habits. So we've actually created, by using AI and behavior science, an underlying platform that uses the modern principles of habit formation that are used to form habits among humans and translated that into organizations. So we've created a real-time closed loop system for managing operations where the system is able to process data in real time, identify operational issues like bottlenecks in patient flow, both looking back, but more importantly, looking ahead before they occur. But we don't just stop there. We actually then help orchestrate the actions for what needs to happen. And finally, most importantly, much like you have preventative maintenance for any process, we create that by creating the right feedback and accountability mechanisms for doing that. So those are the core capabilities of the platform. We actually then combine that with solutions that are pre-packaged of these machine learning models, these technical capabilities, with what you should do as an organization. what process should you have in place, what management practice you should have in place if a capability like this exists. And we've developed those in conjunction with thought leaders and our partners. And finally, a team to help drive the change management and operationalize that, because we know that is extremely essential for success. And by doing these three things, we found the combination of that has given us proven and consistent results across these organizations that we work with. The solutions we talked a little bit about before, we built on top of this automation platform and using this approach. Those span a variety of areas. They span our automated operations solutions, span system operations, emergency department, perioperative areas, and inpatient. And our COVID planning tools that have been newer span both sort of ability to manage demand in real time, but also planning ahead of time as well. So with all of that as context, I'd like to segue now to the mHealth Fairview case study, where I'll be joined by Dr. Karen Baum. Maybe Dr. Baum, just to start with, if you could introduce mHealth Fairview as an organization so the audience is situated and understands your context well.
Absolutely, and thanks for having me. So mHealth Fairview is a 13-hospital system based in Minnesota. We have over 3,000 providers, 30,000 employees, 2 million clinic visits, 100,000 admissions. We are a highly complex, integrated academic health system. And so we have everything from small outstate hospitals and clinics to the University of Minnesota Medical Center, where I practice. Our vision is to deliver breakthrough care. However, we are still combining people and processes, and it should be noted, 2 instances of Epic. So because of a merger, we have 2 different instances of Epic that are currently running for the next year. So we've realized that in order to achieve our vision of breakthrough care, we had to start with transforming care delivery ourselves. So next slide. Again, like many of you, we're a very complex health system and facing a lot of challenges. Our performance improvement initiatives, for example, when they are successful, are sometimes difficult to sustain. They often relied on the heroics of teams doing the right thing every day and going above and beyond, which links back to Mudit's comment about people being burned out. For example, people manually sending faxes and using pieces of paper. In addition, we originally had grown up as multiple different hospitals, and so many of our units and hospitals had developed their own processes and their own workarounds. And also across our sites, it was very challenging to manage accountability because of the variation in processes and even definitions around data and metrics. Also, I think like many of you, we have data, but there's a difference between having data and having actionable data. And in fact, many of us are drowning in data reports these days. We often had stale and conflicting data. So we would get data a quarter behind, but it was too late to right the ship, especially in the time of COVID. And so what we realized is we really needed to transform our processes and our technology. One of our issues was, sorry, Mudit, this issue of stale or conflicting data made people not trust the data. So next slide. So this is how we started to transform our operations. In 2018, we began working with Cuventus to deploy their platform across the enterprise in multiple ways. We started at the hospital level so that we could establish and standardize some best practices. So one hospital at a time, we began to automate and hardwire processes across the span within inpatient, emergency department, and perioperative units, often with lots of discussions and negotiations about how things have quote unquote always worked. Our focus was really on inpatient throughput because we knew if we couldn't unlock capacity we were going to continue to have our bottlenecks that many of us see in our Periop areas, ED areas, and elsewhere, including admissions from other hospitals and outside facilities. And at the system level, we began development of our Mission Control Center, which we call the System Operations Center, or SOC. That's where we use AI to help uncover capacity, identify bottlenecks, proactively optimizing admissions, transfers, and discharges. We currently handle admissions for 9 of the 13 facilities. So really about 80,000 admissions a year. So next slide. So I'm a hospitalist also, just so people know where I still practice as a hospitalist, and so I can attest to some of the changes that we've been seeing. So let's talk about where we began. We didn't have a standard best practice for multidisciplinary rounds. Some hospitals had them, some didn't, some had them twice a day. Who came was variable, what we talked about was variable, different pieces of information were collected. In fact, many times nothing was documented about the discussion. Some patients were not discussed at all. We didn't document when we thought somebody was going home. We didn't necessarily involve the patient and their family in that discussion. This led to the challenges that you're all envisioning. Sometimes people weren't aware that a patient was medically ready for discharge until somebody from the team wandered up to the care coordinator and said, Mr. So-and-so can discharge today. Can you find them a skilled nursing facility or a ride? This leads to all the things that you would imagine, including stress for the team, unhappy patients and families, as well as the potential for missteps on discharge. And our case managers and social workers were spending a lot of time chasing down things at the last minute because there hadn't been that proper preparation. From the leadership side, because everything was so variable and data collection was so variable as well, we didn't have visibility at the leadership level into what patients needed to be escalated because there was an ongoing barrier, or what the common barriers even were and how we might redesign our system to make it more efficient for everybody and better for our patients. So next slide. So this is a screenshot of how our rounds changed. So with Cuventus, the rounds are now standardized across the system and focus on identifying and resolving discharge barriers before the patient is ready for discharge. It involves a consistent group, including case managers, charge nurses, and physicians or providers. So at times it's our advanced practice providers. There can be slight variations from hospital to hospital, which is fine as long as those certain guardrails are met. And you can see here what a patient list, might look like from an electronic health record standpoint. So first, there's machine learning to help flag patients for earlier discharge, like you see in the purple box with the EDD, or estimated date of discharge box. By having that there, it can nudge people to go ahead and do things like change IV meds to oral meds. Has their MRI been completed, or does it need to be completed while they're an inpatient? It really prompts the team to think in a more forward fashion. Then it goes beyond predicting length of stay. So what if you know that the patient's going to be here for another 2 days? What steps do you have to take? We all know the discharge process should be just that, a process. You have to identify patients, identify barriers, and address them up front. And that includes, of course, engaging the patient and the family. The Cuventus AI can find open orders that are critical in that path, and the teams can confirm them, like you see for the MRI in the purple box on the right. That way, we're not stuck chasing down orders on the last day or calling and begging radiology to get that MRI done before the ride shows up. Cuventus can also make disposition recommendations like you see at the top purple box. Many of us have recognized there is an entire process now around dispositions to places like skilled nursing facilities. And so if you haven't thought about that up front and begun to act on it, you can lose multiple days as you start to engage the payer or the patient and family later in the care process than you probably should have.
Yeah, thank you, Dr. Baum. I think this is a really important point. I think, as you mentioned, we've historically seen that it's been really hard with the chaos of the day for care teams to have all this intelligence and be able to be surfaced automatically, because otherwise with 15 seconds a patient in the round, you just don't have enough time to surface these things. And we found through our machine learning, we can enhance decision making, for example, as you mentioned in the EDD side, by capturing almost 40% more patients for discharge than the historical manual EDDs would capture. We've similarly done A/B tests and been able to see that we can have a 20% increase in patients with accurate dispositions that are planned for ahead of discharge. And one of the most unique things I think you did mention is the ability to predict barriers. We found that that's a really hard thing traditionally, because we are asking traditionally teams to just select from a list of all the open orders or select from a checklist, and becomes an extremely manual process. So instead of that, what our barrier prediction engine is doing is running across all the probability distributions. This patient was NPO, and then they had liquid diet, and then their diet's advancing, their IV medications are reducing. So what's the probability of them discharging in 4 hours, 8 hours, 12 hours, 24 hours, 48 hours, all of those probability distributions with the fact that the MRI is open and it's tomorrow, Saturday, what's the probability it's going to be back within that time? And what's the chance that that's going to become a barrier? We run through all those millions of computations and surface things that we are seeing that the care team can then be able to accept or reject. But we found that when these kinds of barriers are captured early in the stay, on average, patients have 3+ fewer excess days. So in all, what we found is if you can move this discharge planning process upstream through this intelligence, not only is it better for the patient and better from the cost efficiency standpoint, it actually also causes, as Dr. Baum was saying, fewer hair on fire problems right as you're about to discharge the patient. But I want to actually talk a little bit about, it's not just about surfacing these predictions. Maybe Dr. Baum, you can touch a little bit about what happens when the care team accepts and confirms a barrier, as is shown in this example.
So I think what's helpful about Cuventus is that it actually leads to data that you can act on. And so in the background, Cuventus helps orchestrate barrier resolution. So our therapy groups and imaging groups can actually see a machine learning driven discharge priority queue, like the one you can see on the left, so that it's not necessarily about who, shall we say, yells the loudest to get the MRI done. It's about, who really needs that MRI done next, so that they can either move on in their care plan or then be discharged. So it's helpful to reimagine what rounds can look like this way. Can we use technology to conduct a non-traditional huddle without therapy in the room, like you could see on the right? Especially in the age of COVID, we're not bringing large teams together to discuss patients as much anymore. And so, these nudges and these priority cues can allow us to maintain that shared mental model of what needs to happen and when and for whom, without necessarily having to bring our teams physically co-located together.
Yeah, thank you, Dr. Baum. I think that was a really important point as well, because in many cases, in some cases, you need that collaboration and buy-in, and in that cases, the nudges help prompt a real-time decision. And the one example is shown here, and actually with one of the partners, we had a modification of that, where not only were we looking at the predicted MRI barrier, but actually prompting for a potential cancellation or rescheduling of that order to an outpatient. And we found about 28-29% of those orders were getting transitioned to outpatient. And in that saved about $140,000 just on that one nudge alone for the institution. And when we looked at how to change behavior and creating new habits, we found that These predictions that we walked you through are very critical. The orchestrations are important. They get us a step forward as well. But we need to go one step beyond that. And we need to create ways of being able to manage accountability and being able to give feedback so that, as Dr. Baum was reflecting before, we are able to sustain the changes, and these new processes do not unravel as soon as you move to the next initiative. Perhaps maybe Dr. Baum, you could share a little bit about how that is done at Health Fairview.
Sure. So again, many of us have lots of reports. We're working on discharge before 11. We chose 11 a.m., as I think many institutions are. One of the unique aspects of Cuventus that we found is the automated escalations that help us identify when we can step in real time. So here's an example of that. So during rounds, each of our units have been asked to identify 2 patients that they believe are good candidates for discharging before 11 and placing the discharge orders before 9 o'clock. This, of course, is to help improve flow. So Cuventus consistently analyzes the data in the background to see where those discharges might be slipping. And so our site leadership and an analyst who's located in our SOC, so not on site, but centrally, they're automatically nudged if the discharge orders for those patients are delayed or if there are outstanding barriers. We don't even need to be logged into Cuventus. They can be nudged through email too. And we know that we can step in to help from a centralized location, and then we can dig into dashboards if we need more information. So here are some of our outcomes. This shows discharges before 11 a.m., which over time have increased almost 30% compared to baseline. The 3 hospitals that we have gone live in, the longest, have also hit their goals for putting in 20% of their discharge orders before 11. And again, being able to give this information to physician leaders has been key. In addition, the charge nurses can escalate their biggest challenges. They're connected on a daily basis. These numbers get reported in our huddles, which go up to senior leadership every morning. And it's really been something that then people can actually be excited about as well when you do get some positives, and then you can spread things that work. So I've been talking about inpatient work, but wanted to also briefly discuss our work at the system level as well. So as I mentioned, we have the System Operations Center, or SOC, and that was designed to help us unlock operational efficiencies and manage flow system-wide. Also, as I mentioned, and this is common, our hospitals were essentially autonomously acting, places before we started a lot of this systemness work. One could be drowning in patients while the other was sending home on-call nurses. So we started with real-time situational awareness into flow and resource constraints. It reduces the manual processes. We were still using pieces of paper to manage our incoming admissions, for example. And now we're also using predictive analytics to identify capacity creation opportunities as well as potential bottlenecks. For example, that discharge by 11, but also nudges with our EDs being particularly busy, et cetera. We're moving towards system management. I wouldn't say we're 100% of the way there. For example, our machine learning model can identify a likely admission from one of our EDs and see that the back of the house, as it were, at that site is at capacity, and suggest that instead of admitting to that hospital, we can admit to one of our sister hospitals. And this is one of the more powerful workflows that we're hoping to make a big dent to try to prevent delays, bottlenecks, boarding, as well as patients that we transfer out of system because we're not level loading appropriately. So here's an example of what we see at our SOC. We have real-time visibility across our sites, and we can see where the bottlenecks are developing. We can collaborate with individual sites, and they can also see this as well. And we can drill down to individual facilities. So this is what we had in place before COVID. We had these facility and system views. So I did want to take a second to talk about what happened when COVID hit. So again, like most of us, we were facing an increasing number of cases. You can see on the left the rise in hospitalized patients early that began in March when we had our first case. Like everybody, we had to figure out how to load balance demand. We actually had a unique opportunity, and we opened up our long-term acute care hospital, became a short-term acute care hospital within 2 weeks, and took all of our COVID patients. So we essentially developed and implemented a COVID hospital. However, we also had a big challenge because we had these 2 instances of Epic, which were unintegrated. So it was a little bit more difficult to gain visibility system-wide into beds and other important issues. So next slide. So to manage the initial surge, we worked with Cuventus over one ridiculously long weekend, as I recall, to launch new situational awareness tools. These tools gave our incident command centers, both our acute ops as well as our system ops, real-time visibility into key pieces that we felt we needed to know. So where our negative airflow rooms were, ventilators, ICU beds, and enabled load balancing of resources across the system. So we knew where all of these were and how many were in use. And we stood this up within, it was definitely less than 2 weeks. I know that. It was amazing. So after we stood that up, we then worked with Cuventus to try to unlock more inpatient capacity through deploying these machine learning modules. So in a disaster, I think most of you have probably realized people lose their ability to think because they're so busy. And patient flow, which is always a problem, becomes everything. So Cuventus helped give us eyes on what really mattered, especially for our ICU beds, which really, I think, as most of us have learned, have become that key bottleneck resource in the age of COVID. So these models run in the background and help us prioritize 2 things. The first is step down or transfer out of the unit. And the second one is discharge candidates to get out of the hospital. So both of those can help relieve pressure from the ICUs as well as create more capacity for the system. So we've integrated these into our daily workflow now. So our physicians review the step down candidates, like who could transfer out. These are prioritized based on a model that we worked with them to develop. And then our SOC staff uses, actually our medical and pharmacy students, believe it or not, use the discharge prioritization queue to start preparing discharge summaries for our hospitalists across the system. And our pharmacy students use this to jumpstart discharge med rec, which has been well received, shall we say, by our hospitalists.
Yeah, to add to Dr. Bum's points, I think we found that a third of the ICU step-down patients can actually be ready for step-down about 8 to 12 hours prior to transfers. And as she was saying, especially in the time of COVID when the ICU capacity was at a premium, unlocking capacity like that can be very significant. And the way the centralized team was able to unlock that has been amazing. We've similarly seen when you have a time, as it was during COVID, the traditional discharge planning processes suffer. Teams are really busy on the front lines. Again, from a centralized standpoint, how do you create similar kinds of knowledge and intelligence of what might be happening for patients, and the ability to have these top med surge candidates for discharge, which are we were able to capture about 30 to 40% more, 25% more in this case for patients for discharge. They can really help both the care teams focus on care progression, but more importantly, they can actually help the centralized teams support those care teams on the ground as well. Dr. Baum, we talked a little bit about how we put in place real-time prediction and orchestration to create capacity. Maybe if you could share about how are you thinking about proactively managing bottlenecks days or weeks in advance, especially in a time like right now?
Sure. So we use the Cuventus planning models and actually were part of some of the original discussions as part of our weekly planning cadence. So the COVID-19 localized scenario planner helps us predict our demand It's not the only model that we monitor, but this one updates with local data and allows us to alter and change the scenarios and the input parameters so that we can play a game of what if. And then we run different scenarios and think about how it will impact our surgical volume.
Yeah, it's also important to consider that the PPE and post-acute demand and other pieces that often go downstream from the impact of COVID are important to coexist with this. We've created versions of that help you model those as well. Dr. Baum also mentioned the importance of and we talked about in the beginning, the importance of accuracy and planning in this. I'll share some of the data we've gathered on that. Here's a comparison between the error of hospitalizations between our model, and in this example, we've used the IHME model. The gray bars show the percentage error of the IHME model predicting 1 day out the number of patients hospitalized in the state, I think, and the purple is showing our errors predicting 7 days out. And we've seen somewhere between 2 to 10x improvement in that error bar, which is, and doing it on a longer time horizon, which is harder to get right as well. And we've made a series of these tools available to organizations free of charge, and we've seen hundreds of organizations use this across the country. Maybe Dr. Baum, you could share a little bit about how have you been using these tools to plan your operations as well?
Sure, and these slides will be available. So I'm going to go through this pretty quickly so we can get to some of the Q&A. So really there's a couple steps to using it. The first step is here, which is the scenario planning itself, predicting the number of admissions. Like any model, it's best within 7 to 14 days. Everybody likes looking at the bell curve. It never turns out that way. But it does give you a directionality, and it is a very powerful model. So again, you can adjust parameters on the left-hand side, like mask compliance or how much people are social distancing, even things like how many beds you have and how many you can go to. And then you can find out when your capacity is going to be reached and the number of admissions over the next 7 days. So once you do that, then you can think about your next steps. So here's an example for what happens with changing mask compliance. And again, this does update regularly. For example, in Minnesota, we meet every Tuesday to talk with the other healthcare systems and agree on certain input parameters so that we can all be using the same inputs and actually run it both locally as a system, but also by region and state, which has been very helpful for us to plan at more of a macro level.
Yeah, and one area I know that specifically has garnered a lot of interest, especially as policies change and population behavior changes across the board, is the set of social distancing policy controls that we introduced, which we had machine learning applied to historical effects of all the different policy changes over the last 3 months in every different area and geography of the country, and use that to model out what might things look like going ahead as things open up. And this sort of combination of being able to both understand how the current rate's going to go, but also being able to understand how policy changes, mask compliance, increased testing is going to impact, allows, as Dr. Baum was saying, them to model what are the different scenarios that might end up playing out. I know, Dr. Baum, you, as many hospitals, are focused on restoring perioperative operations in the last 4 to 6, 8 weeks as well. Can you tell a little bit about how you've used tools again to help drive that as well and help approach that?
Sure, and our program is actually called the Restore program. So, you know, before COVID arrived, we were pretty good at bed huddles, but we weren't very good at even, ironically, knowing exactly how many ICUs we had and how many hours they were in operation. And we had to become much better at that very quickly. So we had to change our approach. So now we feed off of that weekly run that I just talked about. So we predict the COVID demand using the Cuventus model. And actually that's my job this afternoon, is to run that model for mHealth Fairview. We then use that to forecast our surgical capacity for our about 100 ORs. And then we use that to feed into model outputs around prioritizing and scheduling cases, especially if we are worried we might be hitting capacity constraints. So I can show you on the next slide what that looks like. So again, you have to put some inputs in, right? What's your demand buffer, which is key. You'll see that's the top one. So not only how many cases do you think you're going to have with COVID off the scenario planner, but how many extra beds do you want to keep open just in case, especially when so many things are changing. So that's that cushion. And then it's interesting. It prompts some really interesting strategic discussions around things like OR elective surge availability. Do you want to open up on Saturday and Sunday? How many hours do we already set aside for things that are emergent versus non-emergent? Really, the whole idea here is when you run the model, you really want to have very few nasty surprises in the next coming days. We then take that output and put it into our larger planning. So you can see on the left, the elective and time-sensitive surgeries that are possible. And then that gets fed in for us into a larger discussion around other issues. So we also think about, obviously it's not just whether or not there's an OR or a bed. We also discuss, nursing and certain supplies, anesthesiologist, are they taking care of COVID patients? And what countermeasures could we put in place if there is a barrier so that we can be as efficient as possible and take care of, especially these patients who had time-sensitive surgeries held off that really can't wait anymore. So I think in terms of how it's helped us, we all had many procedures delayed and a large revenue loss. And where we're up to just slightly over 90% of our surgical volume, and we're actually trying to see if we can drive above 100. And we're recovering a lot of that revenue that was lost. We're also taking care of patients that really need it. We're also able to bring back some of our furloughed staff because now they're busy. And at the same time, we can assure, the state, the Department of Health, that we've done so in a way that we can still take care of any potential COVID patients. And that's obviously been essential. That was one of the key pieces we needed to have in place in order to be able to reopen to these procedures. So next slide, I think, shows where we're going from here. So looking forward, and I think we all worry that we're going to slip back to our old ways, but I don't think we're ever going to slip back in some of these things. So we need to keep moving. We need to keep being agile. Everything is rapidly evolving, right? You look at the reports every day about where the new hotspots are in their ICU capacity. So we need to continue to use predictive analytics models to help us with planning so that people are comfortable using them. We've already moved from paper, finally, thank goodness, oh my gosh, to digitized maps, and from paper charts to the EHR. I know one of the questions is how this is connected to Epic, and Mudit can answer, but this has real-time data feeds from both instances of Epic for us, which was key. And until recently, we had to figure out the path to discharge manually and barriers manually. Now I think we're really at a point where we can, start to use our brains for the things we need brains for, and use the machine learning for the things that the machines are better, frankly, than the humans are at times. So beyond autopilot, we need to get to the self-driving car, where we, are taking away those non-value added tasks for our frontline workers, things like appointment booking and, identifying who's going where and filling out forms and getting that off of people's desks so that they can practice to the top of their license and have the most rewarding healthcare job they can have and for our patients to have the best outcomes they can have. So I'm not sure. Yeah. So I think the real-time parting thoughts are, you really need to leverage the power of prediction. I think COVID really stripped that bare for all of us, how important having a predictive model was. And you need to use your human resources really wisely. They need to be focused on taking care of patients, focused on keeping the system running, not moving pieces of paper around. The other issue is that in using AI, it's not about the lingo. It's about conveying these very complex ideas in simple ways so that everybody can collaborate well. And that real-time prediction is really important to driving action. That having something that's a quarter behind or 3 months behind is not going to be helpful, especially when we're dealing with situations that change, frankly, hour by hour.
Great. Thanks, Dr. Baum. Thanks, Mudith. We're now going to segue into a Q&A session, and we have a number of questions that have come in throughout the course of the session. As a reminder, if you have questions, you can ask them through the Q&A kind of icon that's at the bottom of the screen. So as maybe for first question, Dr. Baum alluded to this in a prior answer. One of the questions that's come in is just how does Cubentis integrate with your EMR, your EHR, or Epic? Would one of you like to take that?
Yeah, I think I'm happy to give, and Dr. Baum, feel free to add to it as well. Of course, I think a lot of the source data that we pull and learn from comes from existing systems, like in Dr. Baum's case, in ML Fairview, it's 2 different instances of Epic where we're getting these data in real time. We also take certain parameters where it makes sense and write them back into the EMR as well. And all of that is with the goal of minimizing any kind of duplicative or sort of work fatigue from the front lines. This is also single sign-on integrated with Epic as well, so you can use your similar single sign-on and be able to launch it as well. So there's multiple ways we integrate that with Epic, both at a data layer as well as at an application layer as well.
Great.
And it looked like there was another question about how our team is managing its transformation work and appetite for change, given, that's such a big question. So I'm going to try to answer it very simply. I think the right transformation work people want, desperately want. We have an effort around here called getting rid of stupid stuff. And, I think people want to make those transformations to get rid of the pieces of paper, to get rid of, some of the crazy workflow processes. Are people tired? Absolutely. So you really need to think carefully. But I think people also recognize that this has presented a fairly unparalleled opportunity to move work forward in a way that many of us have wanted to do for years. The first time I used an iPad to connect with a patient rather than, running across floors because I'd forgotten to ask them a single question in their family history, I have to say that was delightful. So I think you have to pick and choose what you're asking people to do right now.
Thanks. Maybe a related question then is, have you noticed a change in patient family satisfaction after implementation?
Hey, Deanna. So patient and family satisfaction is being measured. It's a little odd in the time of COVID, right? Because most of us did not allow visitors. So family is, it's going to be interesting to get that data, and it's always lagging, of course. So I think that the short answer is we don't know yet. And there are so many changes happening at once. We need to think carefully about the study design for that to be able to say that there's attribution versus association. In general, With certain things, the patients have very much liked them, but I think we need to drill down a little more to get better understanding.
Makes sense. Couple of questions regarding GMLOS. So how is the multidisciplinary rounding different from using GMLOS, and or just general length of stay predictions, and just your current GMLOS in your facilities? Thoughts on those?
Yeah, I can share a few things on that. I think the GMLOS, like there's institutions certainly using GMLOS as a target, and that's a helpful target to have at times. But what I find are two things. It's a lot more about evolving as the clinical condition of the patient evolves, and it's also about understanding if you are showing the GMLOS of 3 days, which is a geometric mean length of stay across a vast population, and using that to make every patient that has a GMLOS equal, it ends up actually losing trust on the front lines, because some of those patients are not the same as other patients who may be coded as that same DRG. So what we find is by using the actual understanding of the clinical condition of the patient, that they have IV meds or they have a bunch of PT orders open, and being able to then understand and not just use the GMLOS is actually really beneficial to reducing false positive rates, because otherwise you'll get a ton of false positives or everything getting escalated, and that's not very helpful for the care teams. GMLOS is still a helpful target and a way of measuring overall performance. So both at ML Fairview and otherwise, that's used to understand what excess days are still present. But on a per patient basis, they can often end up causing a lot more false positives by kind of demonstrating every patient to be escalated, so to speak, where that may not be the right answer. Dr. Baum, I don't know if you have other things to add to that.
No, I would agree. You have to keep your eye on both. I mean, the reality is GMLOS is how, you know, the public payers calculate payment, and so you can't ignore it. But and it's quite variable. Somebody asked what is ours at our system, and you know, our community hospitals tend to be under 1, and our academic hospitals tend to be over 1 for the ratio, and that's also very common. And so you have to keep your eyes on both. We do, by the way, track turnaround times for beds. The question from Ken, and I'm a huge fan of the IHI bed flow work, and their workshops actually really interesting. So
great, fantastic. Well, unfortunately, we've come to the top of the hour, and out of courtesy to everyone's time, we're going to need to draw things to a close. So first off, Dr. Baum, thank you so much for participating in the webinar. And on behalf of Mudath, Dr. Baum, and the Cubentis team, I'd like to thank everyone again for attending. And this concludes today's webinar. Thank you.